Picture a patient who keeps coming back. After 3 different antibiotic courses over the past year, the urgency and the infection have returned again today. This recurring failure is rarely a matter of bad luck. It is the direct result of incorrect drug selection, wrong treatment durations, and failing to match the specific patient profile. Many standard therapies are losing their effectiveness against rising resistance rates, meaning the old methods for selecting an antibiotic no longer provide reliable results. To overcome this, we have to move past broad-spectrum guesswork and adopt the precise pharmacokinetic targeting outlined in the new IDSA 2025 clinical guidelines. Mastering this targeted approach is the difference between permanently curing a patient and inadvertently contributing to the development of highly resistant bacteria. For decades, we defined complicated UTIs using a long checklist of host factors. If a patient had diabetes or was pregnant, their infection was automatically labeled complicated. The IDSA 2025 guidelines have abandoned that host factor checklist entirely. They replaced it with a single anatomical question: has the infection progressed beyond the bladder? If confined to the bladder, it's an uncomplicated UTI. If it crosses that boundary into the kidneys, prostate, or bloodstream, it is a complicated UTI. This anatomical division determines which pharmacology we apply, matching the drug's path to the exact location of the bacteria. For an uncomplicated infection, we use urinary antiseptics. These are drugs engineered to achieve therapeutic concentrations almost exclusively in the bladder lumen. Because they pass through the systemic circulation without accumulating in tissue, they are ideal for cystitis, but ineffective if the infection has reached the kidneys. Nitrofurantoin is the 5-day workhorse for these cases, as resistance rates for E. coli consistently stay below 10% in most regions. Fosfomycin is the single-dose alternative. It works by inhibiting the MRA enzyme, which halts bacterial cell wall synthesis at its earliest stage. Nitrofurantoin requires specific safety checks. It must be avoided in patients with G6PD deficiency and in late-term pregnancy due to the risk of hemolysis. Notably, fluoroquinolones have been removed from first-line cystitis treatment due to ecological concerns and several black box safety warnings. For uncomplicated cystitis, the objective is maximum local bacterial eradication with minimal systemic exposure. Once the infection extends into tissue, you must switch to systemic antibacterials, drugs that achieve high parenchymal penetration. To select the right systemic drug, the IDSA 2025 guidelines mandate a 4-step empiric algorithm to guide clinical decision-making. Step 1 is to assess severity. If the patient has sepsis, you must immediately escalate to high-power options like carbapenems, piperacillin tazobactam, or 3rd and 4th generation cephalosporins. Step 2 evaluates resistance risk. This requires looking back at the patient's history for any hospitalizations or antibiotic exposure over the last year. Empiric fluoroquinolone use is only appropriate if local E. coli resistance is low and the patient has no recent exposure to that specific class. Step 3 accounts for patient-specific factors. You cross-reference your chosen drug against clinical limitations like severe allergies, renal impairment, or pregnancy. Step 4 is de-escalation. Once culture sensitivities return, you are required to switch to the narrowest effective agent. This 4-step approach replaces the habit of reactive guessing with a clear structure built on clinical deduction. Modern urine cultures are increasingly revealing resistant pathogens that require definitive, heavy-duty countermeasures. One major clinical threat is ESBL-producing Enterobacterales. This comparison table shows why carbapenems, specifically meropenem or ertapenem, are the primary drugs of choice for ESBL-complicated UTI or bacteremia. The Marino trial demonstrated that meropenem is superior to piperacillin tazobactam in these high-stakes scenarios. When you isolate Pseudomonas, you must deploy targeted anti-pseudomonal agents like cefepime, ceftazidime, or piperacillin tazobactam. A common pitfall here is ceftriaxone. It lacks reliable activity against Pseudomonas and should be avoided for these isolates. For the most extreme threats, like KPC-producing CRE, we have to look at newer salvage therapies. These include novel combinations like ceftazidime avibactam or the cytorophore cephalosporin, cefidericol. Effectively treating a resistant UTI requires matching the specific resistance mechanism to its exact molecular countermeasure. One of the most significant modifications in the new guidelines concerns the duration of therapy. The old rule of a default 14-day antibiotic course is no longer the standard. If a CUTI patient is clinically improving on an effective drug, a short 5 to 7-day course is now the recommendation. Remarkably, even with concurrent gram-negative bacteremia, 7 days is sufficient based on current evidence. Shorter courses achieve the same clinical cure while reducing the selective pressure that creates resistant bacteria. Finally, we must consider specific scenarios where standard prescribing habits are often misapplied. Consider asymptomatic bacteremia. A positive urine culture should not be treated if the patient has no symptoms. There are only 2 exceptions: pregnancy and the period immediately prior to mucosal urologic procedures. When treating patients who are pregnant, use the fat cat mnemonic to remember which drugs to avoid: fluoroquinolones, aminoglycosides, and tetracyclines. Safer preferred alternatives include cephalosporins like cephalexin or fosfomycin. Another important consideration is the interaction between methenamine and Proteus infections. Methenamine acts as a prodrug that requires highly acidic urine to release formaldehyde, its active antibacterial component. However, Proteus bacteria produce urease, which generates ammonia and drives the urinary pH up. In this alkaline environment, methenamine cannot function. Understanding these molecular interactions is what prevents treatment failure at the bedside. Modern UTI management is all about precision, replacing outdated checklists with anatomical targeting, algorithmic logic, and committed clinical stewardship.